Hey everyone, welcome back. I scored 260 plus on step 2, and 240 on step 3. And I built this channel for one simple reason, so you don't have to spend hundreds of hours jumping between Amboss, UWorld, and first aid trying to figure out what actually matters. I've taken the high-yield information, the things that are actually tested, and put it all together right here. Today, we're talking about vaccines, and by the end of this video, you're not going to be memorizing random lists anymore. You're going to understand how to think through vaccine questions. So let's start. There are 5 main types of vaccines. But before you memorize anything, there is one question you should always ask yourself. Is this vaccine live or not live? That one question changes everything. Who can receive it, who cannot, whether it needs boosters, and how strong the immune response will be. So let's begin with live attenuated vaccines. Live attenuated vaccines are weakened, but still living organisms. Because they are alive, they can replicate inside the body. And because they replicate, they create a very strong immune response. You get activation of both B cells and T cells. And because the immune response is so strong, you usually don't need frequent boosters. Sounds great, right? But here's the catch. Because it is a living organism, you cannot give it to someone whose immune system cannot control it. And that gives us the 2 biggest contraindications. Number 1, pregnancy. Number 2, immunodeficiency. Now here is the high-yield exception. This is something examiners love to test. Patients with HIV, with a CD4 count of 200 or above, can receive MMR and varicella. Remember this rule: CD4 less than 200, no live vaccines. CD 4200 or above, MMR and varicella are okay. Now let's talk about how to remember live vaccines. Imagine a teacher standing in front of a classroom, pointing at a baby, and shouting, "Attention teachers. Please vaccinate small beautiful young infants with MMR routinely." Every word represents a vaccine. A. Adenovirus. T. Typhoid oral. P. Polio Sabin. Versus varicella. S. Smallpox. B. BCG. Y. Yellow fever. I. Influenza intranasal. M. MMR. R. Rotavirus. Say it once out loud. Seriously, it sticks much faster. Now let's move to killed or inactivated vaccines. These vaccines contain dead organisms. Because nothing is alive, they are safer. They cannot replicate, but because they cannot replicate, the immune response is weaker. You mainly get antibody response, and you need booster doses. The mnemonic here is simple. Imagine you're going on a trip, and that trip could kill you. A trip. A4, hepatitis A. T4, typhoid injection. R4, rabies. I4, influenza injection. P4, polio salk. So whenever you see a killed vaccine question, just ask yourself, is it part of the trip? If yes, you know what type it is. Some vaccines have both a live and killed version. These include typhoid, influenza, and polio. The rule is, oral versions are live, injected versions are killed. Now let's move to our next category. Polysaccharide or subunit or conjugate or recombinant vaccines. First, let's discuss polysaccharide vaccines. A polysaccharide antigen by itself only activates B cells. It does not activate T cells. And because there is no T cell involvement, you do not get good immunological memory. That means weaker protection, and it does not work well in children under 2 years old. The classic example? PPSV23. Remember, polysaccharide alone, B cells only, no memory. Now here is where conjugate vaccines come in. A conjugate vaccine takes that polysaccharide antigen and attaches it to a carrier protein. And suddenly, the immune system responds differently. Now you get T cell involvement, you create memory, and it works even in infants. That is why PCV13, PCV15, and PCV20 are better at creating long-term immune memory compared with PPSV23. Now for subunit vaccines, I want you to picture this: a group of hippie men showing pretty healthy bodies at a wellness festival. Sounds weird, but it works. Each letter represents a vaccine. H4, Hib, M4, meningococcus, S4, streptococcus pneumoniae, P4, acellular pertussis, H4, HPV, B4, hepatitis B. So remember, hippie men show pretty healthy bodies. Say it once, and those 6 subunit vaccines are much easier to recall. Now let's move to our next vaccine type, which is much easier. The toxoid vaccines. A toxoid vaccine uses a toxin, but the toxin has been changed so it cannot harm you anymore. The immune system sees it, learns what it looks like, and creates antibodies against it. The two classic examples, tetanus and diphtheria, both of them require boosters, and both are found in DTaP, Tdap, and Td. Finally, let's talk about mRNA vaccines. The way this works is actually pretty fascinating. A lipid nanoparticle delivers mRNA into your cells. Your own cells then make the foreign protein, and your immune system recognizes it and builds a response. This creates both cellular immunity and humoral immunity. They are safe during pregnancy. The main adverse effect you should remember: myocarditis and pericarditis, especially in young males. To remember the examples, think RCM, like a racing car going around a track; R4, RSV in adults; C4, COVID-19, and CMV; M4, melanoma therapeutic vaccine, RCM. Okay, pause right here. I want you to actually think through this question. A 28-year-old woman is 10 weeks pregnant. She is not immune to varicella. She gets exposed to a child with chickenpox at a family gathering. Can she receive the varicella vaccine right now? Think about it. Varicella is a live attenuated vaccine, and pregnancy is a contraindication to all live vaccines. So the answer is no, absolutely not. So what do you do instead? We'll come back to that when we go through the post-exposure flowchart. But remember this scenario, because it is a classic exam question. Now, who cannot receive live vaccines? Let's make this simple. Pregnant patients cannot receive live vaccines. But breastfeeding? That is safe. Immunocompromised patients also cannot receive live vaccines. This includes CD4 count below 200, SCID, Bruton agamoglobulinemia, and CVID. And children under 1 year old? Generally no live vaccines, except one important exception: rotavirus. Rotavirus starts at 2 months. So that is the only live vaccine you will see under 1 year of age. Now let's talk about two things people often think are contraindications, but they are not. First, premature infants. You vaccinate based on chronological age, not gestational age. The exception is hepatitis B for premature infants under 2 kilograms. You wait until they reach 2 kilograms, or until they are leaving the hospital. Second, minor illness, a cold, an ear infection, a mild fever. None of these delay routine vaccines. Keep vaccinating. Now, let's talk about the pediatric vaccine schedule. I know it feels tough, but I am going to tell you a mnemonic that is going to make your life easier. Just remember the story. At birth, you get BB is for hepatitis B, baby is born, and hepatitis B number 1 goes in. At 2 months, B Dr. Hip, B Dr. HIP, D is for DTaP, R is for rotavirus, H is for Hib, I is for IPV, P is for PCV, and don't forget, B is for hepatitis B. So at 2 months, B Dr. Hip plus B at 4 months. Dr. Hip comes back, but without the B. Dr. Hip came alone this time. D is for DTaP, R is for rotavirus, H is for Hib, I is for IPV, P is for PCV. No hepatitis B, remember. 4 months, no B at 6 months. Dr. Hip returns, and brings B and flu. So, Dr. Hip plus B plus flu. Same vaccines, plus hepatitis B, and start influenza from here. At 12 to 18 months, MAD HPV, M is for MMR, A is for hepatitis A, D is for DTaP, H is for Hib, P is for PCV, V is for varicella. MAD HPV, at 4 to 6 years. Very dim. V is for varicella, D is for DTaP, I is for IPV, M is for MMR. And remember, this is the last DTaP, and the last IPV. At 11 to 12 years, PTM, P is for HPV, T is for Tdap, M is for men ACWY. Pass the message. At 16 years, men boost, only men ACWY booster. That's it. Quick question. A healthy 12-year-old boy comes to clinic. His parents ask which vaccine will protect him from cancers caused by a virus. Which vaccine should be given? The answer is HPV vaccine. Now let's talk complications and contraindications. This is where a lot of marks are won or lost. These are tested rarely but are important. The complication everyone needs to know is intussusception. So rotavirus is contraindicated in anyone who has already had intussusception, and in kids with SCID. Also worth knowing, kids with Meckel's diverticulum or HSP nephropathy already have a higher underlying risk of intussusception. So keep that in the back of your mind and use rota vaccine with caution in these kids. Now let's move to yellow fever. If a patient has an egg allergy, do not give it. Yellow fever is grown in eggs. That's the contraindication. Examiner's favorite. MMR vaccine. This one has several testable points, so let's go through them one by one. First, after someone receives MMR, they need to use contraception for 1 to 3 months. That applies to anyone of childbearing age. Second, egg allergy is not a contraindication to MMR. MMR is grown in chick fibroblasts, not egg albumin. So egg allergic patients can still receive MMR safely. Third, if a patient develops a rash or low-grade fever 1 to 3 weeks after getting MMR, that's a known post-vaccination reaction. You reassure them and send them home. You do not put them in respiratory isolation the way you would for wild measles. But you do want them to avoid contact with immunocompromised patients until the rash resolves. Now DTaP. There are 3 true contraindications here. Anaphylaxis to a prior dose, encephalopathy within 7 days of a prior dose, and a progressive neurologic disorder like infantile spasms or uncontrolled epilepsy. One important point: if a child has uncontrolled seizures, you delay the vaccine, you don't permanently skip it. And if someone had encephalopathy or a progressive neurologic disorder after a prior dose, you switch them to just the diphtheria and tetanus components, without the pertussis. And hepatitis A. This is a killed vaccine, which means it's safe across the board. HIV patients at any CD4 level can receive it. Immunocompromised patients, pregnant women, no problem. It's a killed vaccine, so give it to anyone without thinking. Now let's talk about vaccines in adults. This section gets tested more often than people expect. First is Tdap. Every adult aged 19 and above should get 1 dose of Tdap at some point, replacing one of their regular TD boosters. After that, they just need a TD booster every 10 years. And in pregnancy, Tdap is very important. It is given in every single pregnancy, between 27 and 36 weeks. Not just once in a lifetime, every pregnancy. Next is influenza. Everyone 19 and older should get the flu vaccine every year. If the patient is immunocompromised, only the inactivated injection form is allowed. The nasal spray is a live vaccine, so we avoid it completely in these patients. Now herpes zoster, or shingles vaccine. We now use Shingrix. It is a recombinant, non-live vaccine, given in 2 doses, 2 to 6 months apart. For healthy people, we start at age 50. For immunocompromised patients, we actually start earlier, from age 19. And because it is not a live vaccine, it is safe even in immunocompromised patients. The older vaccine, Zostavax, was a live vaccine and is no longer used in the United States. So now, essentially everyone gets Shingrix. Now pneumococcal vaccine. All adults aged 65 and older should receive it. For adults between 19 and 64, we give it if they have risk factors. These include heart disease, lung disease, liver disease, diabetes, smoking, alcohol use, chronic kidney disease, cancer, HIV, sickle cell disease, asplenia, cochlear implants, or CSF leaks. There are 2 main options for vaccination. You can either give PCV20 alone, which completes everything in 1 shot. Or you can give PCV15 first, followed by PPSV23 at least 8 weeks later. And a simple way to remember it is this. PCV comes first, because it builds better immune memory. PPSV comes second if it is needed. But if PCV20 is used, no extra PPSV23 is required. That's the adult vaccine schedule in a nutshell. Simple rules, but very high yield for exams and clinical practice. Next slides will contain everything you need to know about individual vaccines. One of the most important vaccine from exam point of view is the pneumococcal vaccine. There are 2 main types you need to know. First is the PCV vaccine, which stands for conjugate vaccine. This includes PCV13, PCV15, PCV20, and PCV21. This vaccine is T-cell dependent, which means it creates strong immune memory. That's why it works even in infants and young children. Because it builds better long-term immunity, we always give PCV first when both vaccines are needed. Now here's a very important exception. If a patient gets PCV20 or PCV21 alone, that's already complete protection. They do not need PPSV23 afterward, but if they receive PCV15, then they still need PPSV23 later for full coverage. Now the second type is PPSV23, the polysaccharide vaccine. This one is T-cell independent, meaning it does not create immune memory. It only gives a short-term antibody response. It also does not work in children under 2 years because there is no T-cell help. And whenever both vaccines are needed, PPSV23 is always given second. Now who should get pneumococcal vaccines? All adults 65 years and older should receive it, and adults 19 to 64 years also need it if they have risk factors like diabetes, heart disease, lung disease, liver disease, kidney disease, HIV, immunosuppression, smoking, alcohol use, sickle cell disease, asplenia, cochlear implants, or CSF leaks. In children, PCV13 is given in the routine schedule at 2, 4, and 6 months, with a booster at 12 to 15 months. Now the most important exam rule. Remember this line clearly, 13 before 23. PCV always comes first, PPSV23 always comes second. The gap is usually at least 1 year, but in immunocompromised patients it can be as short as 8 weeks. So the final takeaway is simple. PCV builds memory, so it comes first. PPSV gives broader coverage, so it comes second. And PCV20 or PCV21 alone means you're done. Now let's talk about tetanus vaccine, which is a very important and commonly tested topic. The most important thing you need to know here is that it is the most important vaccine for pregnant patients and also when to choose between tetanus vaccine or immunoglobulin, which is TIG for wound management. Whenever a tetanus question pops up on your screen with an injury scenario, always start by asking one key question. Has the patient received 3 or more doses of tetanus vaccine in their lifetime? This single question guides the entire management. You will know in a bit. Let's first understand the vaccine types and schedule in a simple way. DTaP is given in childhood at 2, 4, and 6 months, then again at 15 to 18 months, and finally at 4 to 6 years of age. After that, Tdap is given once at 11 to 12 years of age. In adults, Td is used as a booster every 10 years. In pregnancy, Tdap is given in every pregnancy between 27 and 36 weeks. Now tetanus immunoglobulin TIG is not a vaccine. It provides passive immunity and is only used in dirty wounds when vaccination history is incomplete or unknown. Now let's apply the wound management rules. If the patient has 3 or more prior doses of tetanus vaccine, then for a clean wound, you only give a vaccine if the last dose was 10 or more years ago, and no TIG is needed. For a dirty wound, you give a vaccine if the last dose was 5 or more years ago, and still no TIG is required. If the patient has fewer than 3 doses or the vaccination history is unknown, then the management changes. For a clean wound, you give Tdap only. For a dirty wound, you give both Tdap and TIG together. TIG is important because it provides immediate protection through ready-made antibodies, and it is specifically used only in dirty wounds when immunity is incomplete or uncertain. After this, routine protection is maintained with Td or Tdap boosters every 10 years. So the key idea is simple. Clean wounds usually just need a vaccine update, while dirty wounds require you to carefully check history and add TIG if protection is not complete. Now let's talk about hepatitis B vaccination and post-exposure management in a simple and practical way. The routine hepatitis B vaccine schedule in infants is given in 3 doses. The first dose is at birth, the second dose is at 1 to 2 months of age, and the third dose is at 6 to 18 months of age. In premature infants who weigh less than 2,000 grams, the first dose is delayed until 1 month of age or until hospital discharge, whichever comes first. Now there is a very important special situation: infants born to hepatitis B positive mothers. In this case, management starts immediately at birth. The baby should receive both the hepatitis B vaccine and HBIG within 12 hours of delivery, but at different injection sites. After that, the vaccine series is completed as usual. The second dose is given at 1 to 2 months, and the third dose is given at 6 months of age. After completing the series, the baby's immunity is checked with an anti-HBs titer at 9 to 12 months of age, or 1 to 2 months after the final dose. If the anti-HBs level is 10 or more, the baby is considered protected, and no further action is needed. If the level is less than 10, the infant is managed as a non-responder, and further evaluation or revaccination may be required. Now coming back to general hepatitis B vaccine response. After completing the 3-dose series, we check anti-HBs 1 to 2 months after the final dose. If it is 10 or more, the person is a responder and no further testing is needed. If it is less than 10, the person is a non-responder, and the full 3-dose series is repeated. If even after 6 total doses the level remains low, the person is considered permanently non-immune, and future exposures are managed with HBIG instead of further vaccination. Now in needlestick exposure from an HBV-positive source, management depends on immunity status. If the person is unvaccinated or a known non-responder, give HBIG immediately and start the vaccine series at the same time. If the person is vaccinated and a known responder, no treatment is needed. If the vaccination status is known but the titer is unknown, check anti-HBs. If it is 10 or more, no action is needed. If it is less than 10, give HBIG and a booster dose. Overall, the key idea is simple. Always assess immunity first, then decide whether the patient needs vaccine, HBIG, or both. Now let's talk about the HPV vaccine, which is very commonly tested. The routine start for the HPV vaccine is at 11 to 12 years of age. If the first dose is given before the age of 15, then the patient only needs 2 doses in total. The schedule is 0 and 6 months. However, if the first dose is given at 15 years or older, then the patient needs 3 doses. The schedule is 0, 2 months, and 6 months. This applies even if the person is older when they complete the series. The HPV vaccine is FDA approved up to the age of 45. However, it is not routinely recommended after age 26. For adults between 27 and 45 years, vaccination is based on shared decision-making between the patient and clinician. Now let's move on to meningococcal vaccines. There are 2 main types, and they protect against different strains. MenACWY is a conjugate vaccine, and MenB is a protein subunit vaccine. Both can be given at the same visit if needed. MenACWY is given at 11 to 12 years of age, with a booster dose at 16 years. If that booster dose at 16 was missed, it can still be given anytime up to age 21 in unvaccinated individuals. Now MenB is different. It is given mainly to high-risk groups between 10 and 25 years of age. It can also be offered between 16 and 23 years as a shared decision-making option. Risk groups include patients with asplenia, complement deficiency, HIV, college freshmen living in dorms under age 21, people traveling to endemic regions such as sub-Saharan Africa, and during community outbreaks. And importantly, MenACWY is required for Hajj entry in Mecca. Now let's talk about hepatitis A vaccine. The hepatitis A vaccine is a killed vaccine, which means it is safe in both pregnancy and in immunocompromised patients. It is given in 2 doses. The first dose is given between 12 to 23 months of age, and the second dose is given 6 months later. If it is missed in childhood, it can still be given later in adolescence or adulthood, using the same 2-dose schedule. Now let's quickly go over a high-yield rule for hepatitis vaccines in pregnancy. Hepatitis A vaccine is safe, so if the patient is non-immune, you can vaccinate during pregnancy. Hepatitis B vaccine is also safe because it is a recombinant subunit vaccine, so non-immune pregnant patients should also be vaccinated. However, hepatitis C is different. We do not treat hepatitis C during pregnancy. Ribavirin is contraindicated because it is teratogenic, and other direct-acting antivirals, such as leterpivir/sofosbuvir, are generally avoided because the risks outweigh the benefits during pregnancy. Importantly, there is no medication that prevents vertical transmission of hepatitis C during pregnancy. So the management is to wait and treat after delivery. Now let's talk about the zoster vaccine, also known as Shingrix. Shingrix is a recombinant subunit vaccine, which means it is not a live vaccine. This is the most important point to remember. It is given in 2 doses, with a gap of 6 months between the doses. In immunocompetent patients, it is recommended starting at 50 years of age. In immunocompromised patients, it is actually started earlier, from 19 years of age. Because Shingrix is not a live vaccine, it is safe even in immunocompromised patients. This is the main reason it replaced the older vaccine, Zostavax, which was a live vaccine and therefore not safe in immunocompromised individuals. Another important point is that Shingrix is still given even if the patient has had chickenpox in the past, or even if they previously received Zostavax. Everyone still gets Shingrix, regardless of prior history. Now let's move on to influenza vaccination. The flu vaccine is given every year starting from 6 months of age. In infants younger than 1 year, only the inactivated form is used. The intranasal vaccine is a live attenuated vaccine, so it is avoided in immunocompromised patients. In general, immunocompromised individuals should only receive the inactivated injectable form. Most other people can receive either the inactivated injection or the intranasal version, depending on eligibility. Now let's talk about varicella vaccine, which is one of the most frequently tested topics in exams. The routine schedule is simple. The first dose is given at 12 to 15 months of age, and the second dose is given at 4 to 6 years of age. For adults who are 18 years or older and have never been vaccinated, the schedule is 2 doses given 4 to 8 weeks apart. Now there are some important groups who specifically need catch-up vaccination. These include close contacts of immunocompromised patients, people who are about to start immunosuppressive therapy or undergo organ transplantation, non-immune healthcare workers, and adults who have never had chickenpox and were never vaccinated. Now let's understand a commonly tested distinction: vaccine strain rash versus wild-type infection. After vaccination, some children may develop a mild rash. This vaccine strain rash usually has fewer than 10 lesions. It can be maculopapular or vesicular, appears 1 to 3 weeks after vaccination, and is only mildly contagious. Even then, contact with pregnant or immunocompromised individuals should be avoided. In contrast, wild-type varicella infection is much more severe. It causes 100 or more vesicular lesions that appear in successive crops, and it is highly contagious. Now let's go through post-exposure management step by step. First, someone is exposed to varicella. The first question you ask is whether the person is immune. This means they either have a documented history of prior infection or have received 2 doses of the vaccine. If the answer is yes, then the person is immune, and no further action is needed. If the answer is no, then the person is susceptible. Now the next question is whether they can receive a live vaccine. This depends on whether they are not pregnant, not immunocompromised, and older than 1 year of age. If they are eligible, then you give the varicella vaccine, ideally within 5 days of exposure. This can prevent or reduce the severity of disease. Even if more than 5 days have passed, you still give the vaccine because it will protect against future exposures. If the patient cannot receive the live vaccine, such as in pregnancy, infancy, or immunocompromised states, then you give VARI-ZIG, which is varicella zoster immune globulin. This provides passive immunity with ready-made antibodies and must be given within 10 days of exposure. There is also a very important neonatal rule. If the mother develops varicella from 5 days before delivery to 2 days after delivery, the newborn should also receive VARI-ZIG. This is because the mother has not yet developed protective antibodies to pass on to the baby. It is important to remember that VARI-ZIG is only temporary protection. Once the situation is safe, such as after delivery or immune recovery, the patient should still receive the varicella vaccine for long-term immunity. Now let's apply everything in a final scenario. A 26-week pregnant woman who works in a pediatric unit is exposed to a child with active chickenpox. She has no history of infection and was never vaccinated. Now we walk through the steps. She is not immune. She cannot receive the live vaccine because she is pregnant. So the correct management is to give VARI-ZIG, and it should be given within 10 days of exposure. After she delivers, she should then receive the varicella vaccine before returning to work. That is the complete, high-yield approach to varicella vaccination and post-exposure management. Now let's talk about special populations, starting with post-splenectomy patients. These patients need very specific protection because the spleen plays a key role in clearing certain bacteria. First, let's go step by step with vaccines. They should receive the pneumococcal vaccine, specifically PCV13 first. Always remember 13 before 23. After that, they receive PPSV23 at least 8 weeks later. Then PPSV23 is repeated 5 years later, and again at age 65. They also need a single dose of Hib vaccine. In addition, they need meningococcal protection with both MenACWY and MenB vaccines. MenACWY is repeated every 5 years. Antibiotics are just as important as vaccines in these patients. They are usually placed on daily penicillin for at least 1 year after splenectomy. In higher risk patients, or those with previous severe infections, this may continue lifelong. One of the most important emergency rules is this: if an asplenic patient develops even mild fever or chills, you do not wait. You start broad-spectrum antibiotics immediately. You do not wait for culture results. Common options include amoxicillin clavulanate, cefuroxime, or levofloxacin. Now here's a very high-yield way to remember why this is so important. Think of shin. Without a spleen, there is a shin-sized gap in immune defense. S stands for Streptococcus pneumoniae. H stands for Haemophilus influenzae. N stands for Neisseria meningitidis. All three are encapsulated bacteria, and normally the spleen helps clear them from the bloodstream. Without it, the body loses a major line of defense. If the splenectomy is planned electively, timing matters. Vaccines should be given at least 2 weeks before surgery so the immune system has time to respond properly. And finally, sickle cell disease should be treated the same way because it causes functional asplenia, so these same precautions apply from childhood. Now let's talk about a very high-yield group, HIV patients. This is important because vaccine decisions depend on immune status, especially the CD4 count. The general rule is simple: all inactivated and subunit vaccines are safe in HIV patients, regardless of CD4 count. Live vaccines are more restricted. Only MMR and varicella can be given if the CD4 count is 200 or above. Now let's go through vaccines one by one in a simple way. Hepatitis A vaccine should be given if there is no documented immunity. It is safe in HIV patients. Hepatitis B vaccine should also be given if there is no documented immunity, and it is safe as well. HPV vaccine is given routinely from 11 to 26 years of age, and from 27 to 45 years it is based on shared decision-making. Influenza vaccine is given every year, but only the inactivated injectable form is used. The intranasal live vaccine is avoided. Meningococcal ACWY vaccine is recommended for all HIV patients starting from 2 months of age, with a booster every 5 years. Pneumococcal vaccination can be given as either PCV20 alone or PCV15 followed by PPSV23. Tdap is given once in adulthood, and then repeated in every pregnancy, followed by TD boosters every 10 years. Shingrix, the zoster vaccine, is also safe in HIV patients because it is not a live vaccine, and it is started from 19 years of age in immunocompromised individuals. MMR can also be given if the CD4 count is above 200. Now let's briefly talk about travel vaccines in HIV patients, which is also commonly tested. Yellow fever vaccine is given for travel to endemic areas in Africa and provides lifelong immunity. Typhoid and hepatitis A vaccines are commonly given for travel to Asia. And meningococcal ACWY vaccine is mandatory for Hajj entry. Now let's talk about vaccines in pregnancy in a simple and high-yield way. Pregnant patients can safely receive several important vaccines. First is Tdap, which is given in every pregnancy between 27 and 36 weeks. This is important for protecting the newborn, and it is repeated in every single pregnancy, not just once in a lifetime. Second is the influenza vaccine. This is given every year during pregnancy, but only the inactivated injectable form is used. Hepatitis A and hepatitis B vaccines are also safe in pregnancy and should be given if the patient is not immune. The RSV vaccine can also be given when indicated, as it is considered safe in pregnancy. Now the most important rule is what not to give during pregnancy. Live vaccines are strictly avoided. This means you do not give MMR, you do not give varicella, you do not give yellow fever vaccine, and you also avoid the intranasal influenza vaccine because it is a live attenuated vaccine. Now let's do a 1-minute rapid-fire revision. Just listen and let it lock in. Live vaccines give a strong immune response, usually don't need boosters, but they cannot be given in pregnancy or immunocompromised. In HIV patients, there is an important exception. If the CD4 count is 200 or above, then MMR and varicella can still be given safely. Killed or inactivated vaccines are different. They are safe, but they produce a weaker immune response, so boosters are needed. Conjugate vaccines are better than polysaccharide vaccines because they create T-cell dependent memory and work even in infants under 2 years of age. Toxoid vaccines like tetanus and diphtheria need regular boosters over time. mRNA vaccines are safe in pregnancy, but you should remember the risk of myocarditis, especially in young males. Rotavirus vaccine carries a risk of intussusception and is contraindicated in children with previous intussusception or SCID. If someone develops a rash 1 to 3 weeks after MMR, it is a vaccine-related reaction. You reassure the patient, no isolation is needed, but avoid contact with immunocompromised individuals. Egg allergy is not a contraindication for MMR, but it is a contraindication for yellow fever vaccine. For tetanus wounds, if the wound is dirty and vaccination history is unknown, give Tdap plus TIG. For a needlestick injury from an HBV-positive source in an unvaccinated patient, you give HBIG and start the full hepatitis B vaccine series immediately. If anti-HBs remains below 10 even after 6 doses, the patient is permanently non-immune, and future exposures require HBIG only on exposure. For HPV vaccine, if the first dose is given before age 15, it is a 2-dose schedule. If it is 15 or older, it becomes a 3-dose schedule. Shingrix is a recombinant non-live vaccine. It is safe in immunocompromised patients and is started at age 19 if immunocompromised, and at age 50 if not. For varicella exposure, if the patient is immune, just observe. If not immune and eligible, give vaccine within 5 days. If not eligible, give VARI-ZIG within 10 days. For newborns, if the mother develops varicella between 5 days before and 2 days after delivery, give VARI-ZIG to the baby. Post-splenectomy patients need PCV first, then PPSV23, plus Hib, plus MEN-ACWY and MEN-B. They also need daily penicillin for at least 1 year. In pregnancy, Tdap is given in every pregnancy between 27 and 36 weeks. No live vaccines are allowed. For travelers, yellow fever is for Africa, typhoid and Hep A are for Asia, and MEN-ACWY is required for Hajj entry. And that's vaccines done. If you can recall most of this without looking, you're in very strong shape for exams.